It is now my pleasure to invite Professor Kerr to join us. You know, Professor Kerr is a very well-known expert in intellectual disabilities and epilepsy, so now we are going to have the neuropsychiatric discussion of another classic. Mike.
Right. Thank you very much, Marco, and the BNPA, and it's a great honor to be here to speak to this audience, particularly about this particular topic. And I think the word challenge is in there to remind me really about it's a challenge speaking to you. I know it's a very multi-professional audience, and I'm not sure how many of you deal with this population, but I hope in my presentation those that do deal with this will gain some insight into at least my approach to this difficult issue, and that those who don't, if they do come across people with intellectual disability and epilepsy in a neuropsychiatric state, will realize there's more to it than risperidone. So, without further ado, I'm going to try in this presentation to mainly talk about what would be seen to be behavioral change and challenging behavior as the key neuropsychiatric challenge in the context of the management of people with intellectual disability and epilepsy. There are clearly many neuropsychiatric issues because people with intellectual disability have the same problems as everybody else, just issues in presentation, evidence base for treatment. But challenging behavior is the one which raises itself in my clinical experience most, and I think is a good place to focus on in our aims to understand how to approach behavior change in people with intellectual disability and epilepsy. And I'm also going to talk about the importance of neuropsychiatric presentations as well. So this is attempting to explain the impossible, which is how we get involved as psychiatrists or neuropsychiatrists in the care of epilepsy and intellectual disability in the UK, which is extremely heterogeneous, from psychiatric services who will not see people with epilepsy. That includes intellectual disability psychiatric services who will say it is all the neurologist's remit, to full management of the epilepsy, which is what I would do. But in general, psychiatry and psychology certainly need to be involved in the treatment of psychiatric disorder and the management of behavior associated with people with intellectual disability and epilepsy, even if that is directly related to the epilepsy. They should be hopefully involved in the assessment of psychiatric change, but they may not be necessarily associated in the assessment in the epilepsy clinic, and they may not be involved in terms of the assessment of the impact of treatment choice and making treatment choice in this population. Unfortunately, the reality is that, as I say, it's very heterogeneous, and some neurology service will be without support at all, and we'll be seeing people with complex behavioral change in the epilepsy and find it very hard to get any guidance. And particularly in child neurology, almost all aspects may be taken on by the child neurology service without much link to child psychiatry services. So it depends really on what you are and what you're interested in, unfortunately, than what a patient's needs are. But there are plenty of needs. So for those who are involved in the epilepsy management, there are many phases to managing this population. I'm sure everybody is aware that people with intellectual disability more commonly have epilepsy, from roughly 0.7% of the general population to roughly 20% of the intellectual disability population. It is usually more severe, but not always, and it is usually more resistant to epilepsy and associated with comorbidity, everything that makes medical treatment more difficult. And in these phases, there are phases to the management and competencies which we need as clinicians. So we need to understand the individual. We no longer can say this is just a group of people who've got a low IQ. The new genetics has led to a much greater understanding of the nature of people's conditions, and this nature of the condition, particularly the genetic etiology and the level of intellectual disability, has an impact on the presentation of psychiatric disorder as it does on the presentation of the epilepsy. We need to understand why we are treating. We don't just treat for the number of seizures. However, we should treat for the number of seizures, and we don't just treat by a certain number of drugs. We treat for the individual, and to treat for the individual, we need to understand the impact of epilepsy and what it does to that individual, so they themselves, if they have capacity, can take part in treatment decisions. If they don't have capacity, the family can be fully informed, or the carers. And we need to think about SUDEP. We already have seen in the last presentation, a case of sudden death in epilepsy. Extremely sad. In intellectual disability, this is a real problem, in many ways because the individuals themselves have their SUDEP safety imposed upon them by others, and that might be what others consider things like the right to bathe when you have seizures, and other issues which we cannot allow. So we have to understand the impact. And if we decide on seizure reduction, which is what is frequently the case, we have to understand treatment choice. I'm not going to particularly talk about treatment choice because we have a very, very large topic here, potentially. We need to manage drug intervention, and this is often the most complicated element of management in this population, mainly because of behavior change, or the apparent behavior change. So people often are restricted drug changes, restricted treatment options because of concern of psychiatric problems, and this restriction is often imposed upon them by professionals who don't manage psychiatric problems, leading to it being a cul-de-sac for patients, particularly if they already have a combination of, say, autism and challenging behavior. And then we need to reduce hospitalization with rescue plans, which I won't go into today. So it's quite a complex area, but those ones in green are all ones, I think, where at a minimum neuropsychiatry, psychologists, psychiatrists can have involvement with in terms of easing the understanding of behavior change, supporting and managing change if it exists, helping in compliance and understanding, helping in understanding capacity. There's a lot of function out there for neuropsychiatric services. So the impact of epilepsy in people with intellectual disability, just to very quickly summarize this for you, because this is something which is underutilized in clinic as a tool to try and get change done, because people have often felt that doctors just impose drugs upon their children and or the people they care for. But of course we do it to try and stop the things that seizures do. And these include mortality, which I've mentioned there with SUDEP. They include frequent hospitalization, greater than the general population, and far greater than any of us would want to happen to us, particularly if they don't have good plans for safety, so they are very frequently admitted to hospital settings. Excuse me. Significant issues with emotion, cognition, and behavior, and very significant issues in terms of social and cultural interaction, where seizures cause a vicious cycle of not being able to go out, so your behavior and mood change, your care goes up, you can't get out, you go out even less, and the treatment of the seizures properly, or the delivery of a good midazolam plan, for instance, for rescue medication, may let that person go out and have a chance of some more social interaction. So, challenging behavior. This is the core of most intellectual disability services through challenging behavior services, psychology, with or without psychiatric input. And I would say it's the central psychiatric presentation. It may not be the central psychiatric problem, but the other psychiatric problems are not as often presented to us, such as anxiety and depression. But it is a final common pathway for other psychiatric disorders and a final common pathway for epilepsy and epilepsy treatment presentations. So it's a good place to start for a neuropsychiatrist. And I'm sure some people here, even if not working in disability services, have been involved in perhaps legal situations or other clinical situations of people with perhaps autism, where the issue of why is this behavior happening in a person with epilepsy who has a low IQ, and what should be done about it. And I think, my general message is that it's quite complicated, and it's getting more complicated with time, but certainly don't jump to simple conclusions. So what are my general view of the facts, which I call them the facts, but by that I mean the things which I believe. And it's only a joke. I mean the facts. And I think, in my viewpoint, when I see somebody in front of me who has an issue about challenging behavior, so any sort of behavior which is challenging to the person, such as self-injurious behavior, or more usually challenging to those around them, I would think my chances of this being a purely related to epilepsy or its treatment is relatively small. It's the tip of the iceberg. It's the tip of my aim for achievement, because if I can prove that in clinic, it looks great, and I can say, well, I'm sure this is a post-ictal phenomena, or I'm sure this is something related to treatment, and I can, prove why I'm there. But unfortunately, it's very rarely that is the situation. Of course, it's usually a mixture, but it's very rarely that's the situation. Is it just purely, is it seizure and treatment influence other factors? This is a lot more common, so medication change influencing your alertness or something because you have less seizures, or medication change making you a little bit more irritable, but you've always been very irritable, so if you take a history, you'll certainly see a lifelong history of these challenges. So therefore, the small changes related to treatment might make a help. And then usually, in my personal opinion, most people, even in the context of new drug change or in the context of anything to do with epilepsy, probably it won't be anything to do with what you're doing, which has made this behavior occur. And that can make you feel a bit, perhaps if you're the neurologist in this situation, a little bit feeling like I've got no influence at all, but I can break it to people that actually what they're doing probably isn't influencing most of what's going on in front of them. And actually, these changes in these very strong drugs is nothing compared to living in misery, or nothing compared to the terrible day service, the long-standing psychological issues, the long-standing issues related to the autism care delivery, which are the ultimate influencing factors on people's behavior. So, however, one of the problems which the clinician faces, and maybe these are the views of people in this audience, is that for those who present to the professional, or some professionals themselves, we can turn that pyramid upside down. And people's beliefs are actually quite the opposite. And that in a clinical setting, people's beliefs are very much initially presented, that what is going on is caused by what you, the professional, has just done, and you are responsible for those changes and have to make that change. And this leads to an interesting environment in the clinic, one which I'm sure many here have been to, where one is at dissonance with the carers and perhaps our colleagues. And that very, very rarely is this an independent seizures thing. So we as clinicians, will usually be sort of trying to avoid this first overall, or should be trying to avoid this first viewpoint, that actually everything in front of you is caused by what you have done as a clinician. It doesn't that we haven't caused problems, it's just that it's not the most likely definition. So in fact, the danger of this particular viewpoint is that all that happens is we just change what we've just done. Just go back, take away the drug. And the person goes nowhere. The person themselves, who may not have capacity, this may nowhere be in their best interest, because it must maybe much more in their best interest to work out whether they've got reflux esophagitis causing the behavior, or whether it's because the carers have stopped bringing the person out, or they've got a new housemate who is a behavioral challenge and has made them behave. So it's not in the person's interest to at least immediately fall for this particular view of thing, unless you have a very clear-cut incremental change related to a treatment change that you can definitely understand. Okay. So how do we try and explain that to people? And I think we try and explain it to ourselves by trying to understand why behavioral change is happening in epilepsy, so we can broaden the viewpoint, look for clues to help us, and try and gain what's best for the person. I'm not expecting to explain all this now, but it's very simple. I'm sure people, you all do this. But the bottom line is this: these behaviors presented in clinical situations in people who are usually not particularly verbally well presenting their symptoms, which makes it so much harder for us to understand, are caused by a range of issues. Psychopathology undoubtedly can lead to behavior change. Physical health very frequently leads to behavior change. Cognitive, adaptive, behavioral factors, so the person's underlying issues with their general behaviors, their general reaction to stress, their reaction to change, autistic features, have a massive impact on people's behavioral change. Genetic factors increasingly understood to be influential in behavioral change. Social environmental factors, which you may or may not be let into in your assessment. You may well not be told the most important factors, and I think that is a key issue, that when you say to someone, has anything happened recently to a collection of carers, a common response will be no, and that will not necessarily be accurate, as you will discover over time that the person's mother might have died, or the person might have been raped or something. You will be told no, first of all, and then you'll have to try and uncover it. And treatment factors realistically certainly can influence behavior. Also, of course, challenging behavior is extremely common in this population. So as a default situation, one should realize that most people will have had challenging behavior already. So the likelihood is that this recent change is the ultimate causation is limited. And this is a study of children and adults in South Wales, looking at the number of people with challenging behavior and the number of challenging behaviors. And as we can see, this is the number with no challenging behaviors. So over half the population have a perceived challenging behavior, and often more than one. This is independent whether they have epilepsy or not. So it's common. So it's underlying and prevalent, and the fact that in your short intervention and meeting with this person that what you're doing is influencing that may or may not be the case. And here we have the point prevalence of 20-odd%, but mental illness, including challenge behavior, over 40% in a different study. So it's common, mental health is common. It's going to pick out the influence of epilepsy is going to be a challenge. Wait a minute. And other things can influence, such as life events. So this is looking at bereavement. Single events like bereavement can affect people's behavior, and this study here looked at individuals referred for behavior disorder and showed that they were 1.68 times more likely to have had a life event. So we do have to ask about life events. Genetics is increasingly important. I'm going to mention genetics because I think it is an area which we understand, and I think it's an area which is interesting neuropsychiatrically because, and as I have somebody who's worked in a quite well-known psychiatric genetic department in Cardiff for 20-odd years, what we learn from intellectual disability tells us much more on a clinical basis about the potential input of genetics than I think what we've learned in terms of enlarged genetic studies. There are numerous single genes epilepsies, and I thank Dr. Muller for this slide, associated with learning disability, dementia, or sort of cognitive loss, and we should look at the causation of the person's epilepsy. There are certain epilepsy syndromes with usually a genetic basis, such as Dravet syndromes, associated with psychological changes. So when we're assessing someone's psychological change, we need to think about the underlying etiology, particularly if we can't find any obvious reasons. And this is useful in people with presentations of cognitive decline, but cognitive decline can also come with other behavioral changes. And in Dravet syndrome, we're increasingly recognizing this is looking at developmental quotients over time in a population of people with Dravet syndrome. The variation of people losing, there are 2 points for each person, the time they're losing or not losing their cognitive changes, and it's very hard for us to pick out these influence of genetics in terms of cognition. We're also getting a closer understanding of specific associations with specific gene abnormalities, epilepsy presentations, and epilepsy and psychopathology. So this is a study, and thanks to Christopher Eaton, who's now working in Birmingham, but was in Cardiff, looking at 20q11.2 deletion syndrome, which all of you will know is of its strong association with psychosis and its interest to psychiatric geneticists for that reason. So here's the deleted region, my project being Christopher's project. And Christopher's trying to understand, which is our next level of understanding genetics, of going into great detail about presentation of psychiatric and epilepsy phenomena in people with known genetic abnormalities, which may open up some hopes for us in our assessment in the future. We already know that about 22q deletion involves about 45 genes. Childhood psychiatric disorder, very high. Schizophrenia, very high. Epilepsy, of quite a range seen in studies. So Christopher identified more previous research. So acute symptomatic seizures are common in this population due to the association with hypocalcemia, repeat unprovoked seizures. Medical reviews have suggested that there's brief non-convulsive seizures are missed, and epilepsy itself is associated with developmental delay. So this is when you look at a screening tool and an interview of people with 22q compared to their siblings. And this is from an epilepsy point, just look at epilepsy presentation. And we can see their siblings haven't got the epilepsy, but a lot of this 22 population of 108 have epilepsy, 10%. But interestingly, in terms of, I think, the borderlands of epilepsy, is this seems to be a borderland population where we see a very large presentation of odd, seizure-like, potentially dissociative, strange motor presentations, far higher than their siblings, associated with 22q. And this is a complicated slide. I'm not going to expect me to memorize it or you, but just to show the very strong association between our epilepsy population with motor manifestations, ADHD manifestations, autism manifestations, and showing that within these individual gene disorders, we're getting a much greater understanding of causation. Now, in terms of the assessment of challenge behavior, what it tells us is to look deeper, and not that other things aren't influencing it, but if you already have a genetic condition associated with these, or if you've got 22q and you're beginning to behavioral change, you might worry about psychosis, not worry about necessarily your drugs. So treatment-related change, well, always possible, absolutely never ignore it. Rarely definite, but sometimes can be definite. And the evidence in terms of controlled trials is relatively weak, but it's a real situation. This is within intellectual disability. It's stronger outside of intellectual disability. And the main problem is within trials of intellectual disability, where there's probably only 13 to 15 ever done, validated measures of behavior are rarely used. So it's almost impossible to judge what the change of behaviors are in studies. It's a shame because it's the overwhelming side effect that influences people's choice, but it's the least looked for. The impact of epilepsy on behavior within the intellectual disability population should be no more than that which has been described, particularly by Professor Trimble and by others, in terms of association between pre-ictal, ictal, and post-ictal. But we should obviously do this in this population, being challenged by communication to inform us. So pre-ictal, we have auras and warnings, so there's no difference of an aura and warning. We're not necessarily, in fact, very rarely will get the eloquence, I think, to describe mystical symptoms, but we may do. We should never, we should always assume capacity to discuss these things. But we certainly will see people with good behavioral observation who have auras or who may present some sort of auras to us. The ones presented to me are usually more physical sensory type auras. In terms of ictal, the challenge of ictal behavioral change in people with intellectual disability is non-convulsive status mainly, so fluctuating cognitive change without an obvious seizure. In someone with already difficult epilepsy, one must be thinking of non-convulsive status, which is probably a lot more common in this population, missed. And also within that are people who may have fugue-like events, which may be ictally related. And then post-ictal, we have the same range as the general population of confusion, automatism, and psychosis. Anything else we might know? This is a study published in Epilepsia looking at the balance of a prospective study of change and psychiatric presentation, new psychiatric presentation in 1 year by Dr. Turkey, who is an MD student of mine. To cut a long story short, as compared to a control group, people with epilepsy presented significantly more of organic disorder and any psychiatric disorder compared to the control group by level of intellectual disability, gender, age, and housing. So having a seizure disorder does mean you are more likely to have a new psychiatric problem in the next year compared to the general ID population. So, having said all that, we can see that seizures, drugs, genetics, life, and underlying issues like autism affect someone's presentation of challenging behavior. So how do we try and unravel that in a clinic? Well, we look at trying to define things, which I don't think people normally do, but challenging behavior, problem behaviors such as aggression, self-injury, destruction. Clearly, this is not how things are described to us in clinic. They normally just say the behavior's got a lot worse, or they're more aggressive or something, and we quite often find that that's quite a hard and elusive issue to pin down objectively. And there are various scales that can be used. The MOAS is quite simple, and clinical assessment can be very difficult because of objectivity. We quite like to look at a psychiatric diagnosis, and if you're not a psychiatrist in LD who's used to trying to to make these diagnoses. There are a range of scales which are quite good if you want to use them. As you can imagine, the challenge is psychiatric diagnosis without verbal presentation of disease. So one has to go for more classical biological changes to try and judge assessment and assess change. This is too complicated, but it's in the slides. My preferred technique is to give the carers and the patient a full disclosure of this whole slide here, to try and say to them, there's a lot potentially going on. How can we unravel all these hypotheses at once? And if you're lucky, you may find that it is in fact seizure related, and there's been a clear association with seizure change. If it's associated with seizure improvement, I consider it to be usually an adjustment disorder, and continue to offer more support to the person to get through that disorder. But it may well be psychogenic type seizures, maybe a psychogenic situation. It may be side effects quite clearly, and particularly if it sounds like drug side effects, not just one more behavioral outburst in a 7-month period when challenged by a carer, which is a hard thing to pin down as a drug side effect. Or it may be physical comorbidity, which is psychiatrists are increasingly interested in, but in this population is extremely common. Well, what treatments are out there if you finally refer on and find some support? Well, there are treatments. There are psychiatric services of psychiatrists, and I do recommend in the UK we are one of the very few places that's got such a service. But they fundamentally are no different to what we have in psychiatric practice, apart from the complex interventions around behavior support teams. The trials for evidence of managing behavior, just a little bit outside my comfort zone here, but my assessment of the trials that exist are that specialist behavioral teams work just, have quite a small impact. Anger management works just. These are randomized controlled trials. So we have interventions, we have psychology services, challenging behavior teams. The challenge is to get people to the interventions, to get the teams if you're a neurologist, to formulate your presentation that the team just doesn't send it right back and say it's all due to epilepsy, so you can't ever get anybody involved, and to get people out there to get support, because these teams are, like everybody else, overwhelmed by epilepsy and overwhelmed by disability. So whilst they're disability teams, if you add in the complexity of someone with strange drugs with strange epilepsy, your chance of getting the same package is reduced. Antipsychotics, no, but this is the overwhelming intervention in the United Kingdom and everywhere in the world. So antipsychotics, this classic study here showed, using the MOAS, which I mentioned before, which is quite an easy scale, 86 non-psychotic people presenting with challenging behavior, being given risperidone. And here we see the placebo effect, the effect of risperidone. So MOAS goes down if you're getting better, and the effect of haloperidol. So 4 weeks, maybe haloperidol slightly better, but at 12 weeks, you are better giving nothing than giving risperidone. Now, this fact has not something that has remotely been able to be embedded in the minds of professionals or carers or care deliveries, because this is the intervention, long term. And in people with intellectual disability and epilepsy, these drugs do increase your seizure count. So we've got a long way to go. There is the Royal College of Psychiatrists is doing all sorts of things about this in the media and things, but in reality, people will go along and have their risperidone dosage changed in relation to a presentation from a carer. So to my conclusion, the successful management of epilepsy and successful management of psychiatric challenges is a bidirectional issue in people with intellectual disability. Therefore, neuropsychiatric support is essential within epilepsy treatment settings, and I know the balance is such that mainly those of us who are neuropsychiatric, or those who deliver neuropsychiatric services, including intellectual disability, fundamentally do not supporting the neurologists, okay? So the neurologists are isolated. They can get support or they can get zero support in this situation. The nature and understanding of behavioral presentation is more complex and fluid, with genetics, life stress, seizure frequency, and treatment all offering influences on individual psychiatric presentation. Thank you very much.
clinical talk. So we have time for questions. Yeah?
You said that risperidone was as good as giving nothing.
Oh, sorry, nothing was better. Nothing is better than risperidone.
But in this trial, of course, risperidone was given or placebo. I wonder whether in this situation the placebo actually had a useful function, not perhaps on the patient himself, but on the scenario. I totally agree with you that we should try not to start these drugs, and certainly this evidence should very much encourage people to stop the drugs again rather than to keep them going. But there may well have been a placebo response on the whole scenario because something was being done. There was an expectation amongst the carers and the patient that, well, maybe the patient, but mainly the carers, that things would get better, and things did get better.
Okay, well, I will completely agree with you, Marcus. Unfortunately, I can't prescribe placebo, but you are quite right. I mean, the advantage of doing RCTs in people with intellectual disability, particularly if they don't have capacity, is we are teasing out the reality of people's sense of safety about something being done. And this is what we see in that context. And we see it in medication reduction as well, which I led a very long-term medication reduction study, which makes recruiting people with mystical experiences look like a doddle. And it led to a clear understanding that there were changes when you take away antipsychotic drugs, but there are also quite a lot of changes when you take away placebo in people's perceived changes of behavior.
The point is also that challenging behavior is a symptom.
It's a final common pathway for lots of things. Yeah.
Obviously.
I'm particularly interested in Christopher Eaton's research on the genetic component. I'm a psychiatrist who works with deaf and deafblind people, particularly with forensic issues. I have a man with Usher's, that's autosomal recessive condition, learning disability, psychotic illness, and absent seizures, but he also may have some sort of tonic-clonic phenomena in that when you put hands on to him to sign, suddenly he goes rigid. We've done all possible known investigations like MRI scans, CT scans, blood tests. He's got normal pressure hydrocephalus. And so I'm wondering if the research done on children is applicable to a man in his 50s who is still having seizures despite the treatment by neurologists and regular reviews, etc., and whether it will throw some light on his predicament.
Well, I think it's yes. The answer is yes, but this is something you have to search either through known databases of genetic syndromes and what behavioral symptoms are seen with those, or through the internet and self-health groups. What we have, our problem with research in children and our current adult population is these people, haven't had the potential of a lifelong diagnosis, if that is a positive thing, which may have added certain forms of health promotion. So someone with Down syndrome may well have expectations through their life of how their health's promoted. So how a person now with 11 would be at 50 with this syndrome compared to this person might be completely different. So it's quite hard to communicate that. But you are never too young to get a genetic diagnosis, in my particular view. We diagnosed somebody who was 57 with Rett syndrome, and the previous oldest person was 40 in the world. And the person's care was still found extremely helpful to understand their breathing disorder. And it really was a very simple diagnosis. You just had to take a child, an early developmental history. So yes, you're never too young. But it will bring on to one point, which is these unusual behaviors you find when people have got genetic syndromes are trying to understand them. And I think that situation of those very reflexive events, which I have no idea whether they're seizures or not, is not uncommon that we see people with these complex neurodevelopmental problems have a lot of other manifestations, which are not just necessarily epilepsy.
Hi.
Any other questions?
Hello.
Huh?
Hi. Thank you very much. It's been a really interesting talk. I'm a geriatrician. With regards to your slide on assessing behavioral change, the physical illness is there as something important. And although I agree I'm a little bit like you. Sometimes physical illness, people are trying to come up to a diagnosis of infection. I think we're overdiagnosing UTIs, overdiagnosing physical things that aren't there. Whereas sometimes something really subtle that's not really in the realms of pathology. It can be something premenstrual. It can be constipation that's, you know, really not pathological. So I think our role should be in pushing aside the over-medicalization of these issues and maybe giving it to a more important role to the carers, to the education around behavioral changes, and a sneaky way to prescribe placebos, to prescribe a bedtime snack or a nighttime midnight snack. And it's a very good way to stop people getting midazolam and haloperidol in the middle of the night in medical wards.
Yeah.
That's all I wanted to say.
I agree with you, but I think the physical presentation is quite important in people in this population, and you can't overdo it. But you know, people will often present things in a focused way about what you've last done, even though the person's got a 30-year-old history of all sorts of things, and particularly its drug side effects. So someone's not eating. If someone's not eating, unless they're on zonisamide or topiramate, you have to make sure there's not a GI problem, and even if they're on those two drugs. And I think the problem is people that don't have the capacity. So our best interest is always to try and make sure that others' decision-making isn't getting in the way of proper medical practice.
Okay, thank you very much. Thank you, Mike. Excellent.